Okay. So good morning once again, and we are in stomach and duodenum. So in the last class, we were discussing about the various arterial supply of the stomach, like the left gastric artery arising from celiac plexus, that is celiac artery. Then the right gastric artery arising from the common hepatic artery. Then you have right gastroepiploic artery arising from the gastroduodenal artery, and the left gastroepiploic artery arising from the splenic artery, and you have short gastric vessels. Then of course various cells like the chief cells producing pepsin, parietal cells producing the acid. Then various investigations we were discussing about the endoscopy, contrast X-rays, ultrasound, endoluminal ultrasound, laparoscopic ultrasound, then various other investigations like CT scan, MRI, PET, and angiographies. So we were also talking about gastritis, like we have discussed that type A is autoimmune, whereas type B is H. pylori induced, and there is other types like reflux, erosive, stress gastritis, menetrious disease, lymphocytic gastritis, eosinophilic gastritis, granulomatous gastritis, and HIV induced also. So that is the picture of erosive gastritis. Then briefly we have started peptic ulcer. So wherein I have stressed the term is a bit misnomer because it is not induced by pepsin, mainly by acid, because in the absence of acid, the ulcer will heal. And the other evidence that it is acid induced is, it is high incidence in high acid levels like Joerlinger-Anderson syndrome. And recently, not recent means not exactly recently, at least 20 years back, we have detected that it is mainly due to H. pylori, though NSAIDs and cigarette smoking do also play a part. And of course, duodenal ulcers are very common compared to gastric ulcers. The common sites being the first part of duodenum for duodenal ulcers, whereas gastric ulcer, it is on the lesser curvature. We also discussed that as previously noted, now there is no acute or chronic ulcers. It is mainly a spectrum of disease, that is from acute to chronic ulcers. Then you have gastric ulcers. One thing is, gastric ulcers, you have to be very careful because malignant ulcers will also mimic benign ulcers. So in fact, it is said that if there is a gastric ulcer, treat it as malignant till it is proved otherwise. Regarding symptoms also, previously much was said, but now the symptoms of either gastric or chronic are indistinguishable. By symptoms alone, you cannot say whether the person is having a gastric or duodenal ulcer. Similarly, the treatment, grossly, it is anti-secretory PPI and H. pylori eradication. Nowadays, elective surgery is rarely performed because of the availability of conservative measures, and not only that, there are long-term sequelae of surgery. We have also noted that the three major complications of peptic ulcers are perforation, bleeding, and stenosis. Now let us today discuss in detail about the various ulcers. So chronic duodenal ulcer. Of course, the incidence is falling because of the extensive use. It is now OTC product, PPIs, usually either a OMS will be taken by the patient whenever he finds that he is having something gastric. And not only that, we are now regularly enforcing H. pylori eradication therapy also. So because of this, the incidence is falling. Of course, still it is a disease to reckon with. And nowadays, the main change is it is seen in older persons rather than younger individuals like previously. Of course, men still dominate for chronic duodenal ulcers, and peculiarly O-positive patients are more prone for chronic duodenal ulcer, whereas A-positive for carcinoma of the stomach. So coming to pathology, the ulcer will penetrate the mucosa and also muscularis. So, and it will heal by fibrosis. So that's why the duodenal cap, it is the first part of duodenum is usually called as duodenal cap. It is deformed, and there may be stenosis also because of this cicatrization. And serosa on the operation table, once you how to recognize, because the ulcer is inside. So how to recognize is if you rub the serosa, what is called as shiny pepper. Can anybody tell me what is the shiny pepper is? Shiny pepper appearance. What does it mean? Yes, no idea. I'll show you, of course, what is shiny pepper. Salt and pepper. That is another description we make, salt and pepper appearance. But shiny pepper is not salt and pepper. Yeah. Speckled red dots. Yes, correct. But I asked you, what is this appearance is? I didn't ask you that. I asked you, what is shiny pepper? Of course, it is not of academic interest, just outside our subject. Just want to discuss. Because too much subject is not conducive for learning. Yeah. Anyhow, let us proceed. So I'll show you what is that later. So it is petechial hemorrhages. Of course, these petechial hemorrhages will have that appearance of this shiny pepper and will be red dots. Yes, correct. So ulcers usually are on the anterior surface of the first part of duodenum. This is the commonest site. Whereas posterior can also occur, and both combined anterior and posterior can also occur. When they are there, then we call it as kissing ulcers. So both anterior and posterior ulcers can touch each other. That's why they are called as kissing ulcers. Then, of course, as already we have discussed, anterior, because there is no structure anterior to the surface of the anterior surface of the duodenum, they tend to perforate. If they penetrate the serosa also, then there is peritoneal cavity there, so they can perforate. Whereas posteriorly, usually duodenum or other structures are there. So usually they don't perforate. They may bleed because, as already I have told you about the artery. So the artery that is there. So the gastroduodenal artery. So they can bleed, right? So now coming to the histopathology, what is happening is there is destruction of the muscular coat also, and the base is formed by almost serosa. So it is filled with granulation tissue, and one important aspect is endarteritis obliterans is there. This is very characteristic of peptic ulcer. And you can even see the termination of nerve fibers among fibrosis. That's why they are exposed. The nerve fibers are exposed, and that's why there is pain in the duodenal ulcers. Now, let us go to the shiny pepper appearance. So, these are the something similar to our red chilies, but they are too hot. So these are the shiny peppers. So they are similar to our red chilies, but they are hotter than our red chilies. So this is the appearance. You can see, as somebody has already pointed out, red dots after the cirrhosis. So this is the first part of duodenum. You can identify by this is called as a pre-pyloric vein of Mayo. So once that is there, distal to it is the first part of duodenum. So you can see that there is what is called as shiny pepper appearance or petechial hemorrhages on the serosal surface of the duodenum. Then coming to gastric ulcers, contrary to duodenal ulcers, they are common in both sexes, equal incidence, and mainly seen in much older population, that is more than 40, and low socioeconomic group also, both for duodenal also mainly seen in low socioeconomic, because of H. pylori is prevalent among low socioeconomic group because of less hygiene situations. Then coming to the pathology, the ulcers are large. Suppose duodenal ulcer is about 0.5 to 1 centimeter. These ulcers are more than 1 centimeter, and any ulcer that is more than 3 centimeters, they are called as giant ulcers, and you have to be careful before dubbing them as benign ulcers. One of the important differential diagnosis of a benign and malignant gastric ulcers are this size. The bigger the ulcer, the more chance that it is malignant. So they are mainly seen on the lesser curvature, and because posteriorly there is stomach, this pancreas, it will penetrate pancreas and vessels also, and here also fibrosis and stenosis will occur. Then it will assume the shape of hourglass or teapot stomach. So hourglass you all must be knowing. So this is the hourglass stomach. Suppose the ulcer is fibrosed here, then this is the shape of the stomach. Teapot, of course, I'll show you. Of course, you all must be knowing what is teapot. So that is the hourglass stomach. Then the ulcers of a benign nature will have clear margin. That is another distinguishing factor between a benign and malignant. In benign it is clear cut, whereas in malignant it is diffuse. and all mucosal folds will converge onto the ulcer. So the ulcer will be clear-cut edge with mucosal folds converging like this. So the mucosal folds will be converging onto the ulcer margin or edge. So that is the appearance of a benign gastric ulcer. This much said. So three factors I told you is large ulcer, diffuse margin, and folds not converging onto the margin. You have to suspect malignancy. That's why any ulcer, gastric ulcer, to be regarded as malignant unless proved otherwise. Now, what are the clinical features of peptic ulcers in general? The most common symptom being the pain. So how is this pain? It is not regular, it is intermittent. It is felt in the epigastric region. It is characteristically described as gnawing pain. So gnawing pain is characteristic. That means it will not allow the patient to do his regular routine. So it disturbs his or her routine in gastric ulcers. Whereas in duodenal ulcers, eating, that is food, may relieve the pain. In fact, previously we used to describe if the ulcer is duodenal, the pain will occur on empty stomach. That means after 2 hours after eating. Whereas in gastric ulcer, it is after half an hour because the food will stimulate pain. Okay. Whereas there is another very characteristic feature of duodenal or gastric ulcer that is called as periodicity. That means though the ulcer is present throughout, patients may not have symptoms. He may be quite asymptomatic, and this period of pain-free period may be there for weeks or even months, but only to return again. So that is the importance. So don't think that this ulcer, if it is there, if the patient is asymptomatic, that there is no ulcer. It may be there, but is symptom-free. So that is very characteristic of peptic ulcers, right? Vomiting, of course, patient may induce vomiting, but usually it is present in stenosis because of obstruction. Another characteristic feature of a peptic ulcer is water brash. What is this water brash? Can't see board. Board is very clear cut. I don't know why you cannot see the board. It is, now you see. Still you are not able to see the board. I don't think so. It's very clear cutly seen. Yeah. Now what is this excess salivation? No, sorry. It's not excess salivation. Water brash. Excess salivation is excess salivation only. In any aphthous ulcers or any tongue problems, acid coming back good. So the burning fluid, so the fluid in the mouth will be having acid because of reflux. So acid, which is also called as acid brash also. So water brash. So the patient will have mouthful of refluxed fluid, gastric fluid that is containing acid. That's why it will be both sour and burning in nature. Because of this reflux also there is heartburn. Okay. Right. Now, another feature of peptic ulcer is sometimes the patient may gain weight in duodenal ulcer. Can you tell me why there is gain in weight in duodenal ulcers? Pain relieved by food. Good. So, once pain is relieved by food, the patient will have an habit of taking food frequently without working much. So, patient will have weight gain. So, some people used to carry biscuits to the workplace and then eat them. ఉన్నారా మనుషులు?
ఉన్నారు సార్ 39 అలాగే ఉన్నారు సార్.
Okay. So there was brief interruption because of net problem. So we could restore it to some extent. So now, I was talking about alteration in the weight, and one of you have correctly pointed out that there may be weight gain in duodenal ulcer because of frequent intake of food to overcome the pain, because pain is relieved by food. Whereas it is other way around in gastric ulcers, because the food induces pain, so usually they will not take food. That's why they may lose weight also. There may be bleeding also sometimes. Usually it is microscopic. That's why these patients are anemic. And but sometimes it may be hues, and then the patient may have in the form of hematemesis, or if it is milder, melena. So 3 forms of bleeding. One is microscopic, it will lead to anemia, whereas melena, there is bleeding, but it is not significant. Only thing is the patient may complain of melena, and if you see the stools for examination, if you send, there will be blood. Whereas hematemesis, if it is massive, there may be hematemesis. This is, of course, is a complication of duodenal or gastric ulcers. So these 6 or 7 symptoms are very important: pain, periodicity, vomiting, water brash, heartburn, alteration in weight, and bleeding. So many symptoms are there, but the findings are very sparse. So on clinical examination, you will see that there is nothing much to examine except that there is epigastric tenderness. So other than epigastric tenderness, you cannot find any finding unless it is complicated. Suppose it is stenosis, you may see a visible gastric peristalsis. So clinical examination is only tenderness. Now, once you suspect a peptic ulcer, the first thing you do is send it for gastroduodenoscopy. This is the investigation of choice. So you have to see all parts of the upper GI tract. That's why the so-called U maneuver is done, so that you will see gastroesophageal junction also. You may miss so many problems at the gastroesophageal junction. So can you tell me what are those problems at the gastroesophageal junction? So if you are following the previous class, you will be knowing the problems at gastroesophageal junction. Hope all of you are listening, because I'm not getting any response. Yeah. GERD. GERD, what are the findings you can see on GERD at the gastroesophageal junction? That is the question. Disease, of course, is GERD. I'm asking about the findings. Anyhow, GERD is one answer, I do agree. So, I told you in the earlier classes, malignancy, very good. So, gastroesophageal junction, particularly now in the incidence of proximal malignancy is increasing. Distal is decreasing, proximal is increasing. In fact, in Western people, it is the proximal carcinoma. Then, of course, at the gastroesophageal junction, you have another problem, that is paraesophageal or sliding hernias. I told you in my earlier classes that Trendelenburg position, if you can put the patient and take contrast X-ray, you can be able to see the sliding hernias. Then we have another important problem in the last exam on esophagus. I have given you so many bits on that. That is the Barrett's esophagus. So these are all the problems at Barrett's esophagus. So these are the problems. Now, so that is important. You have to see not only GE junction, you have to see the pre-pyloric, the pyloric, because here it is very common, gastric ulcers. Then first part of duodenum, and suppose it is a post-operative case. So if it is a post-operative case, that is the gastrojejunostomy. So what is that? So post-op case. So suppose gastrojejunostomy is done like this, then with the tube, that is endoscope, this is the afferent loop, or otherwise called as proximal loop of jejunum. This is the efferent. So afferent, efferent. These are the loops. So you have to go into this, like this tube, and you have to go like this. So you have to see both afferent and efferent loops for any stomal ulcers, which may be either benign or malignant. One important aspect is you have to take multiple biopsies, particularly for stomach ulcers, because you have to exclude carcinoma. And for duodenal ulcers, they regularly do, the gastroenterologists will regularly do what is called as rapid urease test and C13-14 breath test. So these are part of the ulcer protocol for gastroenterologists. And of course, age old is there. Now, routinely we don't do this unless for academic purpose or for any demonstration purpose. That is the barium meal series. So you give barium sulfate to the patient on fasting, And then you take serial pictures, one after 10 minutes, then another half an hour, different positions, right anterior oblique also you will take. So if it is a chronic duodenal ulcer, what you see is the absent or deformed cap. I already told you that ulcer, because of fibrosis, there will be deformed cap or even absent cap. There is another characteristic deformity that is called as trifoliate deformity. What does it mean? Trifoliate means, what is this trifoliate deformity? The name indicates the answer, trifoliate deformity. Yes, try is easy. T-R-Y, not T-R-Y, it is T-R-I. But you have to try for the answer. Trifoliate. In intermediate, you were studying botany also, isn't it? Difficult question. I'll show you what is trifoliate deformity. Yeah, 3 leaves like, good. So it is 3 leaves, secondary duodenal diverticular. Very good. So 3 leaves like this. Duodenum first part will be, there will be diverticular like this. So that is the trifoliate deformity in the first part of the duodenum. So this is the trifoliate deformity. Anyhow, I will show you that X-ray shortly. Whereas in gastric ulcer, what is called as niche and notch. So these are there. Of course, these are mainly for academic interest, so don't bother much about them. So this is the appearance of a chronic duodenal ulcer. So it is present just beyond the hilum. So chronic duodenal ulcer, right? Then you have, this is the so-called trifoliate deformity, typical of a chronic gastric duodenal ulcer. Whereas here you can see there is no duodenal. Here there is cap, but it is deformed. Here there is no cap even. It has gone directly into second part of the duodenum. So that means the cap is destroyed. So these are the barium meal findings of a chronic duodenal ulcer. Whereas a chronic gastric ulcer will have what is called as a niche and notch. Like this. Okay. So this is, they are both in same line. So because it is borrowed here, there is fibrosis and then this will be pulled inside. So this is the niche and notch. Right? Now, what is the differential diagnosis for the chronic duodenal ulcers or chronic peptic ulcers? Because there is no typical sign of chronic duodenal ulcer. Anything, whenever the patient complains of pain in the epigastrium and of course heartburn or water brash, you have to suspect all these problems. That is non-ulcer dyspepsia. So far, I have undergone, I think, thrice upper GI endoscopy. But always the gastroenterologist says it is non-ulcer dyspepsia because nothing is found. I'm happy one way, but unhappy because there is no finding. If there is a finding, I can know the cause. But the gastroenterologist says you are perfectly all right, don't bother. So non-ulcer dyspepsia. That is the very common, particularly in people with tension. Surgeon job is tense. So there is nothing surprising that I have what is called as NUD, non-ulcer dyspepsia. Then of course gastritis, drug abuse and all those things can produce gastritis. GERD we have discussed extensively. Cholecystitis. Nowadays, whenever a patient complains of pale abdomen, first thing we exclude is cholecystitis rather than duodenal ulcer. That is the status quo. Then chronic pancreatitis, also one of the entities. When we discuss about that, we can talk about it more detailedly. Another important thing, any person of above 40, if he complains of pain abdomen, and you have to suspect carcinoma stomach, exclude it first. Okay, so these are the differential diagnosis. Now, if you leave it alone like that, what can the ulcer become? So, three important things already I told you, that is perforation, bleeding, stenosis. So for gastric ulcers, it will assume hourglass or teapot stomach. Of course, it can also perforate. Bleeding can be there. Penetration is more common posteriorly into the pancreas. And the patient may even complain of pain radiated to back if there is penetration into the pancreas. But the dreaded complication is malignant transformation. So that is very, very important. You have to suspect. Now, treatment in a nutshell is chronic gastric ulcers. You have to be conservative, mainly either H2 blockers, PPIs, sucralfate. Because sucralfate, as I told you, it will restore the mucosal barrier. Then surgery, mainly if you suspect malignancy, and the surgery of choice for gastric ulcers is partial gastrectomy. Whereas for duodenal ulcers, of course, our main aim is to relieve the pain or symptoms, to heal the ulcer and prevent recurrence. To prevent recurrence, you have to use what is called as eradication therapy. So conservative, almost 90% of cases are treated conservatively, and that is mainly lifestyle modification. So what is that? That is, you have to avoid all these things. NSAIDs, if you have the usage of NSAIDs, immediately they have to be stopped. Or some milder varieties have to be taken. Then alcohol, smoking, spices, all these things will cause pain aggravation. To relieve pain and because meals will reduce the pain, what the patient is advised is small, frequent and bland diet without spices. So small, frequent, bland meals. That is the dictum for chronic duodenal ulcers. Of course, various drugs are there like H2 blockers, you all know, you all passed pharmacology. So ranitidine, famotidine, roxetidine, then PPAs, any number are there still coming. Omeprazole, esomeprazole, lansoprazole, pantoprazole, rabiprazole. Individual physician has individual choice. So myself, I will prescribe mainly rabiprazole or esomeprazole. Both are very effective. Whereas for this pantoprazole is mainly used for any drug induced or as a prophylactic. Then antacids, previously very well famous, but now gradually waning, but still everybody knows what is lysine or other drugs. Gelusil is another one. They contain mainly aluminum hydroxide. If it is taken singly, it will cause constipation. Whereas magnesium trisilicate, it will cause diarrhea. So both can be offset by combining them. But the problems with them is there is calcium absorption is decreased, so osteomalacia and milk alkali syndrome can be there. Of course, sucralfate, already I told you, it will protect the ulcer, colloid bismuth. Eradication therapy, you all must be knowing by this time, that is the triple resin. That is a combination of 3 drugs, triple, daily, twice, and then it is taken minimum 1 week, but usually gastroenterologist will prescribe for 2 weeks. It will contain one antibiotic, that is clarithromycin or amoxicillin, antiprotozoal, usually tinidazole, then PPI, either omeprazole or lansoprazole. So that is in a nutshell the treatment, conservative treatment. In the next class, we will go for surgery, right? Any doubts? So it seems to be no doubts. Thank you. Right. Girish Leda?
Yes. Girish Ramana.
That మీరు వచ్చేస్తారా డైరెక్ట్?
Girish telling like that. Girish